Everyone assumes the patient is doing fine. But something doesn't feel right. The breathing is just a little faster. The patient pauses between sentences. Their hands feel cooler than they did an hour ago. Experienced nurses know that patients rarely deteriorate without warning. The warning signs are simply quiet. Welcome to the Clinical Red Flag Files, Respiratory and Perfusion Clues. I'm Mary Jane Millionaire, registered nurse. In this audiobook, you'll learn how to recognize the earliest clinical clues of respiratory compromise in poor tissue perfusion, often before the monitor shows anything abnormal. Because in nursing, early recognition doesn't just improve outcomes, it saves lives. Chapter 1. Why respiratory and perfusion changes come first. Every serious clinical emergency begins long before the emergency itself. Respiratory failure doesn't begin when oxygen saturation falls. Shock doesn't begin when blood pressure drops. The body gives warnings, small warnings, quiet warnings. Unfortunately, they're often overlooked because they don't appear dramatic. One of the biggest misconceptions in healthcare is believing that normal monitor readings automatically mean a stable patient. They don't. A pulse oximeter measures oxygen saturation. It does not tell you how hard the patient is working just to maintain that number. Likewise, a normal blood pressure doesn't necessarily mean the tissues are receiving enough oxygen. A patient may already be compensating while every monitor in the room appears reassuring. This is why bedside assessment remains one of the most powerful tools in nursing. The patient's breathing pattern, the effort required to breathe, their ability to finish a sentence, the temperature of their skin, the color of their fingertips. These are clues that no monitor can fully interpret. Experienced nurses learn to recognize these patterns before the alarms sound. Because once the monitor finally changes, the deterioration has often been happening for quite some time. Throughout this book, you'll learn how to connect these subtle observations into meaningful clinical decisions, helping you recognize respiratory compromise and poor perfusion earlier, intervene sooner, and provide safer patient care. The goal isn't simply to react to emergencies. It's to recognize them before they happen. Outro. This is just a preview of the Clinical Red Flag Files, Respiratory and Perfusion Clues. The complete audiobook includes practical bedside assessments, clinical frameworks, real-world case scenarios, and 50 original NCLEX-style practice questions with detailed rationales to strengthen your clinical judgment. Chapter 1 Preview. Approximately 2 minutes. Why respiratory and perfusion changes come first. Every serious clinical emergency begins long before the emergency itself. Respiratory failure doesn't begin when oxygen saturation falls. Shock doesn't begin when blood pressure drops. The body gives warnings, small warnings, quiet warnings. Unfortunately, they're often overlooked because they don't appear dramatic. One of the biggest misconceptions in healthcare is believing that normal monitor readings automatically mean a stable patient. They don't. A pulse oximeter measures oxygen saturation. It does not tell you how hard the patient is working just to maintain that number. Likewise, a normal blood pressure doesn't necessarily mean the tissues are receiving enough oxygen. A patient may already be compensating while every monitor in the room appears reassuring. This is why bedside assessment remains one of the most powerful tools in nursing. The patient's breathing pattern, the effort required to breathe, their ability to finish a sentence, the temperature of their skin, the color of their fingertips. These are clues that no monitor can fully interpret. Experienced nurses learn to recognize these patterns before the alarms sound. Because once the monitor finally changes, the deterioration has often been happening for quite some time. Throughout this book, you'll learn how to connect these subtle observations into meaningful clinical decisions, helping you recognize respiratory compromise and poor perfusion earlier, intervene sooner, and provide safer patient care. The goal isn't simply to react to emergencies. It's to recognize them before they happen. Chapter 2. Early respiratory red flags. Before hypoxia, one of the greatest mistakes in clinical practice is waiting for oxygen saturation to fall before becoming concerned. By then, the patient's body has often been compensating for quite some time. Respiratory deterioration rarely begins with alarms or flashing numbers. Instead, it starts with subtle changes that are easy to dismiss. A respiratory rate that's just a little faster than normal. A patient who pauses between sentences to catch their breath. A voice that sounds weaker than it did an hour ago. These small changes may seem insignificant when viewed individually, but together, they tell a story. Your patient's respiratory system is working harder than before. One of the earliest warning signs is tachypnea. Not severe, not dramatic, just a gradual increase in breathing rate. It's the body's way of trying to meet increasing oxygen demands long before oxygen saturation begins to decline. As respiratory stress continues, breathing patterns begin to change. Respirations become shallower, more rapid, less efficient. Patients may not tell you they're short of breath. Instead, they simply stop talking as much. They answer with one or two words instead of full sentences. They conserve every breath without even realizing they're doing it. This is why observation is one of the nurse's greatest clinical tools. Watch how your patient breathes. Listen to how they speak. Notice the effort behind every breath, not just the numbers on the monitor. Because normal oxygen saturation doesn't always mean normal breathing. Sometimes, the patient who appears comfortable is quietly approaching respiratory compromise. The best clinicians recognize these changes early, not because the monitor told them, but because the patient did, long before the monitor ever could. Preview note. In the complete chapter, you'll learn how to identify mild tachypnea, recognize subtle changes in breathing patterns, use speech as an indicator of respiratory reserve, detect increasing work of breathing, and understand why silent hypoxia can delay recognition of a deteriorating patient. These concepts form the foundation of early respiratory assessment and timely clinical intervention. Chapter 3. Work of breathing, what nurses must watch. Imagine standing outside a patient's room. The monitor displays an oxygen saturation of 98%. Blood pressure is stable. No alarms are sounding. From a distance, everything appears under control. But as you walk closer, you notice something the monitor can't measure. The patient isn't simply breathing. They're working to breathe. Every inhalation requires visible effort. Their shoulders lift with each breath. The muscles in the neck tighten. The spaces between the ribs begin to pull inward. The body is recruiting every available muscle just to move air. This is called the work of breathing. And it may be one of the most important assessments a nurse can make. Because oxygen saturation tells you how much oxygen is attached to hemoglobin. It does not tell you how much effort the patient is spending to keep it there. As respiratory illness progresses, the body compensates. Breathing becomes faster. Accessory muscles become more active. Energy consumption increases. For a while, the patient keeps up, but no one can compensate forever. Eventually, the respiratory muscles begin to tire. Here's where many clinicians make a dangerous mistake. The patient suddenly appears calmer. Breathing slows. The visible struggle decreases. It looks like improvement, but sometimes, it isn't improvement at all. It's exhaustion. When a patient who was fighting for every breath suddenly becomes quiet, don't assume they're recovering. Ask yourself a different question. Have they stopped struggling because they no longer have the strength to continue? Respiratory fatigue is one of the final warning signs before respiratory failure. Recognizing that transition can mean the difference between timely intervention and a life-threatening emergency. The monitor may still look reassuring, but the patient is telling you another story, one that can only be understood through careful observation. Because experienced nurses don't simply watch the numbers, they watch the patient. Preview note. In the complete chapter, you'll learn how to identify accessory muscle use, recognize visible respiratory strain, distinguish true improvement from respiratory fatigue, and understand why the work of breathing is often a more sensitive indicator of deterioration than oxygen saturation alone. These bedside observations can help nurses recognize respiratory compromise before decompensation occurs. Chapter 4. The SpO2 Trap. There's one number in healthcare that many clinicians instinctively trust. 98%, 99%, 100%. A normal oxygen saturation often brings reassurance. But what if that number doesn't tell the whole story? What if your patient is quietly deteriorating while the pulse oximeter continues to display perfectly normal readings? This is what I call the SpO2 trap. Pulse oximetry is an incredible tool. It tells us how much oxygen is attached to hemoglobin. But it cannot tell us how hard the patient is working to maintain that oxygen level. It cannot measure respiratory muscle fatigue. It cannot measure the energy being consumed with every breath. And it certainly cannot predict how close a patient is to respiratory failure. Imagine two patients. Both have an oxygen saturation of 98%. The first is resting comfortably, speaking in full sentences, and breathing without effort. The second is breathing rapidly, using accessory muscles, pausing after every few words. Visibly exhausted, the monitor sees two identical numbers. But the nurse sees two very different patients. One is stable, the other is running out of reserve. This is why experienced nurses never treat a monitor reading as the entire assessment. Instead, they ask a more important question. What is the patient doing to keep that oxygen saturation normal? Because compensation has limits. As the body works harder, respiratory muscles fatigue. Energy stores become depleted. Eventually, the patient can no longer keep up. And when oxygen saturation finally begins to fall, the opportunity for early intervention may already be slipping away. The goal isn't to react when the numbers change. The goal is to recognize the clinical story long before they do. That's where nursing judgment becomes one of the most powerful tools in patient care. Because the monitor provides data, but the patient provides the diagnosis. Preview note. In the complete chapter, you'll explore why pulse oximetry has important limitations, how to recognize a patient who is deteriorating despite a normal SpO2, and why oxygen desaturation is often a late manifestation of respiratory compromise. You'll learn to integrate monitor data with bedside assessment, helping you detect deterioration earlier and intervene before critical instability develops. Chapter 5. Early Perfusion Red Flags. When nurses think about circulation, many immediately look at the blood pressure monitor. But what if the earliest signs of poor perfusion never appear on that screen? What if the patient's body is already struggling to deliver oxygen to tissues, while the blood pressure still looks perfectly normal? The body is remarkably intelligent. When circulation begins to fail, it protects the organs that matter most, the brain and the heart. To accomplish that, it redirects blood away from less critical areas, especially the skin and extremities. And that's where the bedside nurse gains an advantage. Because before the monitor changes, the skin begins to tell the story. A hand that feels cooler than it did an hour ago. A patient whose fingertips become pale. Capillary refill that takes just a little longer than before. A sudden layer of cool, clammy perspiration without an obvious explanation. These are not random findings. They're the body's quiet signals that tissue perfusion may already be declining. Unfortunately, they're easy to dismiss. It's just a cold room. The patient is anxious. They've always had cool hands. Sometimes those explanations are true. But sometimes, they're the first chapter in a much more serious clinical story. One of the most dangerous misconceptions in patient care is believing that normal blood pressure guarantees adequate perfusion. It doesn't. Patients can maintain a normal blood pressure while their body works tirelessly to compensate for hidden circulatory compromise. By the time hypotension finally develops, the opportunity for early intervention may already be narrowing. That's why experienced nurses don't assess circulation with a single number. They assess the patient. They observe skin color. They feel skin temperature. They compare capillary refill with previous assessments. They notice trends that no monitor can recognize. Because perfusion doesn't fail all at once. It fades quietly, and the nurse who recognizes those subtle changes has the opportunity to intervene before compensation becomes collapse. Preview note. In the complete chapter, you'll learn how to assess early perfusion changes using skin temperature, skin color, capillary refill, and unexplained diaphoresis. You'll also discover why peripheral assessment often detects circulatory compromise long before blood pressure changes, helping you recognize compensated shock and other life-threatening conditions earlier in the course of deterioration. You've just listened to a preview of the Clinical Red Flag Files, Volume 3 Respiratory and Perfusion Clues. But this is only the beginning. In the remaining chapters, you'll learn how to recognize compensated shock before hypotension develops, connect respiratory effort with tissue perfusion, identify high-risk clinical patterns, know exactly when to escalate care, communicate effectively using the SBAR framework, document patient deterioration with confidence, and apply everything you've learned through realistic case studies and 50 original NCLEX-style practice questions with detailed rationales. Whether you're preparing for the NCLEX, strengthening your bedside assessment skills, or caring for critically ill patients, these practical lessons are designed to help you recognize deterioration earlier and intervene with confidence. If you'd like to continue learning, the complete edition of the Clinical Red Flag Files, Volume 3 Respiratory and Perfusion Clues is available now on Amazon in Kindle and paperback formats. Thank you for listening, and thank you for the work you do every day to keep your patients safe. Remember, the best nurses don't wait for the monitor to confirm deterioration. They recognize it at the bedside. Recognize earlier. Prioritize faster. Save more lives.